السلام عليكم ورحمة الله. بنرحب بحضراتكم في المراجعة بتاعة الموديول الصعب اللي هو الهيد اند نيك. وزي ما احنا متعودين فهنعرض شوية حالات وحضراتكم بتجاوبوا عليها عن طريق الشات، ولما نخلص أي حد عنده أي سؤال أو استفسار في حاجة كان ذاكرها يعني مش عارف يفهمها أو كده ممكن يسأل بإذن الله تعالى. فهنبتدي الأول. And this is the first case, CT scan of the maxillofacial area showing the paranasal sinuses and orbits. Okay, in this particular case, and it's easy to appreciate that there is a maxillofacial fracture on the right side, and this fracture involves the anterior wall of the maxillary sinus, the posterolateral wall of the sinus, the zygomatic arch, and the lateral orbital wall, all the components of zygomatico-maxillary complex fracture. And in this type of the fracture, you should look to the orbit because there may be associated entrapment of the inferior rectus muscle, and also there may be complications in the globe itself. And in this case, there is evident rupture of the globe. The globe is collapsed and there is intraocular air. The next case is a CT scan of the paranasal sinuses and orbits in the soft tissue window and the bone window. Okay, and this is squamous cell carcinoma, or you mean that there is a carcinoma of the ethmoidal layer cells, and this tumor has eroded the medial orbital wall in both sides with interorbital extension, maybe extension into the sphenoid sinus. And you know that most of the paranasal sinuses tumors are squamous cell type, and few are of other types, but you should mention first that this is a carcinoma. And if you are asked about the differential diagnosis, and you mention this may be sarcoma or lymphoma or metastatic deposit. The next case is a selected section from the CT of the larynx. Okay, you mean that this is a glottic cancer? You see that there is a soft tissue mass in this particular area, and if you look to the opposite side, you see that this is the false vocal cord, not the true one, and is identified by the fat which is present in the false vocal cord, meaning that the level of the true vocal cord is not yet seen in this section. Then you should say that this is a lesion which is carcinoma, of course, the most common solid mass in the larynx, and it is in the supraglottic area. Then if you want to see if it has extended above or below, then you should have the coronal images, or you should have more sections to identify the level of extension. It's very important in unilateral laryngeal masses, and you look to the opposite side, which is the normal side, to see the level where you are cutting. The next case is an MRI of the petrous bone, let us say, and this is T2, the FLAIR image, and this is T2 weighted images. Then supraglottic cancer of the previous case, this is the right answer. Then what about this case? Yes, and this is cholesterol granuloma or cholesterol cyst, which is typical location and typical signal. You see a cystic lesion of high signal intensity in the apex of the petrous bone, and this lesion is of high signal in T1, T2, and FLAIR images. It does not enhance with contrast, and this is typical site and the typical signal of cholesterol granuloma. And this patient, 28 years old, with a change in the voice and right vocal cord palsy. Yes, and this is glomus vagal, a good answer. Because the tumor has pushed the internal and external carotid arteries posterior to both arteries, and this is typical location of glomus vagal tumor, where the carotid body tumor is located between the bifurcation of the internal carotid artery, the common carotid artery. Then this is a male, 59 years old, with a CT scan of the parapharyngeal space. Yes, and this is right. This is parapharyngeal lipoma, and you see the low signal of the lesion compared to the low signal of the fat, and you see some internal shadows within the lesion, meaning that this is not air. And you compare by the air in the oropharynx, this is parapharyngeal lipoma, right answer. This patient had two sections, one at the level of the floor of the mouth and one at the root of the neck. And there is a complaint of progressive dysphagia. Okay. Lingual thyroid or ectopic thyroid, right answer. You see the strongly enhancing mass at the floor of the mouth, corresponding to the posterior aspect of the tongue, and whenever you go to the level where you should see the thyroid gland, and you do not see any thyroid tissue, and this is ectopic thyroid or lingual thyroid. And you know, about 70 or 75% of patients with lingual thyroid, this will be the only thyroid tissue available for the patient. And sometimes you got a lingual thyroid and some thyroid tissue at its normal location. Next is a female, 72 years old, with history of nasal polyposis, and this is a CT scan without contrast for the paranasal sinuses. Yes, this is fungal sinusitis because of the hyperdensities inside the paranasal sinuses, and fungal usually complicates the sinonasal bulbosus type of pansinusitis because this is a chronic illness, and frequently it is complicated by superadded fungal infection And this is the case where you see extensive opacification of the ethmoidal air cells and the maxillary antra, as well as the nasal fossae, with hyperdensities characteristic of fungal infection. Next is a female child, 5 years old, with a left-sided proptosis. Hemangioma, yes, the answer is right. But we have two types of hemangioma in the orbit. The pediatric type, which is known as the capillary hemangioma, and this is a diffuse type, as you can see, and you may got some signal void vessels inside the lesion itself, and the cavernous hemangioma, which is a well-defined lesion seen in adult population. This is an appearance of the capillary type of orbital hemangioma, which occurs in the pediatric age group. Next case is a male, 50 years old, with rhinorrhea and the episodes of epistaxis. Okay. Olfactory neuroblastoma, this is a good answer. Whenever you are asked about the differential diagnosis of a lesion that is involving the ethmoidal air cells with intracranial extension and orbital extension as well. This location is suitable for Icezino neuroblastoma, which is also known as olfactory neuroblastoma. But many times squamous cell carcinoma can do so. Skull-based meningioma can also do so. Skull-based metastasis and lymphoma all can be included in the differential diagnosis. But you should know that neuroblastoma is much more aggressive than what I have mentioned, and it has well appreciated intracranial component. And if you see some cystic changes at the cranial side of the tumor, this is very good sign to suggest this particular type of the tumor. This is olfactory neuroblastoma. The differential diagnosis should include skull-based lymphoma, skull-based metastasis, paranasal sinus squamous cell carcinoma, and the olfactory neuroblastoma. Next case is this is a child with a CT scan of the brain and orbit before and after contrast injection. Yes, which side? Retinoblastoma. Which side? Bilateral retinoblastoma. Yes, this is bilateral retinoblastoma. The tumor on the left side is very big and has extended outside the confinement of the globe, and it contains dense calcification, as you can see. The right side tumor is represented by dense mass of calcification inside the orbit and some of the soft tissue component. The answer is bilateral retinoblastoma. Next case is a CT scan of the orbit and paranasal sinuses. Yes, subperiosteal abscess, and the diagnosis should be orbital cellulitis secondary to ethmoidal sinusitis. Yeah, this is the inflammation of the ethmoid, which should be on the same side of the inflammation in the orbit, and the inflammation has extended into the orbit, forming a subperiosteal abscess, and this is typical for orbital cellulitis and the subperiosteal abscess. Next case is a mandibular panorama, and showing this lesion, and you can see here. What do you mean by DC? Yes, dentigerous cyst. No, this is not a dentigerous cyst because the dentigerous cyst is a unilocular cystic lesion, and the apex of the tooth is included in the cyst while its root is outside the cyst. But here you got a lesion which is big with erosion of the related teeth, and there is a missing tooth here, and this is classic of a meloblastoma or adamantinoma of the mandible. Next case is a CT scan of the orbit. And actually, aneurysmal bone cyst is one of the rarities in the mandible, and you should not diagnose this possibility from the plain film or the mandibular panorama, because there are much more common lesions in this area. But whenever you have the CT scan or an MRI and you see the classic fluid levels, then you may diagnose aneurysmal bone cyst. What do you think of this lesion? Right eye retinoblastoma? No, the calcium is outside the globe. This is a cystic lesion inside the orbit, and this is the globe which is pushed inferiorly. Yes, and this is dermoid cyst. Dermoid cyst is a lesion, cystic lesion intraorbital, does not enhance, may contain calcium, may contain fat, and the diagnosis of physis bulbi, you should see the globe, and the globe is totally collapsed. It contains calcium. Then you may say that this is end stage globe, and meaning that this globe is no more fit for anything. Then this is a lesion which is located in the fat, and this lesion is cystic and it contains calcium. Then the diagnosis of dermoid cyst is the most likely. In this case, you have MRI sagittal T1 and axial T2, axial T1 post contrast, and coronal T1 post contrast. In this case, we have two lesions. We have two lesions in the suprasellar area. Suprasellar germinoma, no. Colloid cyst, no. Russell's cleft cyst is not a suprasellar lesion. Then if you look carefully here, you see a cystic lesion contains fluid which is almost similar to the CSF in all sequences, and this is a suprasellar arachnoid cyst. The second lesion is this one, and this one is located posterior to the arachnoid cyst, and it does not enhance with contrast material. And you know, the only suprasellar lesion which is located usually in the pediatric age group, and it does not enhance, and this is hamartoma. Yes, this is tubercinarium hamartoma and the arachnoid cyst in the suprasellar area. And sometimes these two lesions may occur in the same patient, like in this case, and you should be careful about this one, which is the only lesion solid lesion, I mean, which does not show contrast enhancement. This patient presented after maxillofacial trauma. Yes, and this is globe rupture. You see that the border of the globe is discontinuous in this area. You see that the lens has been dislocated and fallen down in the posterior chamber, and you see some fracture line in this area. Globe rupture, of course, is a serious complication of maxillofacial trauma, and it should be notified clearly in the report whenever you are writing a report for or interpreting a case of maxillofacial trauma. You should look carefully for the integrity of the globes. This is mandatory because rupture globe meaning that it is irreversible damage to the globe and is no more suitable for anything. And here is an MRI of the maxillofacial area. When you got a cystic lesion in this particular location containing fluid-like signal, it's a little bit higher than the vitreous humor. Then what do you think? Epidermoid. Okay. Another suggestion, dermoid. Yes, and then if you dermoid and epidermoid are good possibilities, but if you look carefully for the characteristic location, which is very close to the nasolacrimal duct, then you should think of a nasolacrimal duct cyst or an infected nasolacrimal duct or a dacryocystosil. And of course, orbital dermoid and epidermoid occur either at the inner canthus or the outer canthus of the globe. But if the lesion is intimately related to the region of the nasolacrimal duct, then you should include this possibility in the differential diagnosis. Adult male, 30 years old, with an intraorbital mass on the right side. No, post contrast, both are post contrast. Yes, and this is cavernous hemangioma, classic appearance in an adult, well-defined lesion, homogeneously enhanced, may contain some foci of calcium, and this is a classic appearance of a cavernous hemangioma, which occurs usually in adults. The next case is MRI of the paranasal sinuses, T1, T2, coronal T2, and coronal post contrast with fat saturation. And here are some of the suggested differential diagnosis: adenoid cystic carcinoma, lymphoma, melanoma, metastatic deposit. Okay, lymphoma, melanoma. Actually, as I have mentioned, the most common lesion in the paranasal sinuses is the carcinoma. And carcinoma may be the squamous cell, which is the most common, may be adenoid cystic carcinoma or mucoepidermoid carcinoma, like those arising from the salivary glands. This should be the first possibility in your answer, and this should be the first possibility in your report. Then whenever you are asked about the other differential diagnoses for this lesion, and you mention lymphoma and metastatic deposit, then carcinoma should be suggested first because it is the most common by far malignant lesion in the maxillofacial area. Then this case is a female child, 6 years old, and these are orbital CT scans, axial and coronal, and the orbital MRI. This is axial T2, and this is coronal T1 post contrast with fat saturation. Yes, the answer is right, and this is lymphangioma because of the fluid levels. The orbital mass, ill-defined, a big mass in the orbit of a child, and then there are some possibilities like capillary hemangioma and lymphangioma, for example. And lymphangioma is characteristically showing multiple fluid levels, especially on MR examination. This is orbital lymphangioma, and you know that the hemangioma, lymphangioma, and some other lesions are included under this title, which is known as lymphovenous malformation. Then this patient had left abducens nerve palsy, dysesthesia, and divisions of the trigeminal nerve 1 and 2, headache, facial pain, and diplopia. Gardingo syndrome. Yes, the answer is good, very good. And you see here opacification of the middle ear cleft and mastoid ear cells denoting automastoiditis. You see some erosive changes in the apex of the petrous bone. On MRI, you got opacification of the mastoid and middle ear cavity with no post-contrast enhancement, but you get enhancement of the apex of the petrous bone, and this is known as apical petrositis or vitreous epicitis, which is a known complication of automastoiditis, and it will result in Gardingo syndrome as you answered, and this will include the abducent nerve palsy and some paresthesia on the distribution of the divisions of the trigeminal nerve. The next case is a male patient, 30 years old, with a CT scan. Yes, and this is classic appearance of mouse floor dermoid cyst. This is the sac of barbel. You see a lesion in the floor of the mouse when the globules of fat. The diagnostic of dermoid cyst at the orbital floor. This is MRI of the salivary glands showing a lesion in the superficial lobe of the left parotid gland. Yes, in the sac of marble, right answer. Then this is Wharton. The age is not fitting. The appearance is not fitting as well. But you know that Wharton tumor is seen in males particularly, and those who are of relatively old age, and they are smokers. But this is a young female, and this is classic for pleomorphic adenoma of the parotid gland. If the lesion is of low signal in the T1, high signal in the T2, meaning that it contains a lot of water and it is towards the benign side of the tumor. But if the lesion is of intermediate signal in the T1 and T2, then water content is less, and you may suspect malignancy, which is not true in all cases. This patient had the right facial nerve paralysis for 2 weeks. Yes, the heterogeneity is not does not does not make the pleomorphic adenoma as a possibility. It can be homogeneous, it can be heterogeneous, and I mean the Wharton tumor contains a solid component and a cystic component. The age is important, and the history of cigarette smoking or smoking in general is important also. Then what do you think about this case? Shukran, thank you. And this patient with right facial nerve paralysis, this is a CT scan, and this is axial T1 post contrast for the petrous bone. No, and this is not acoustic neuroma. All what you see here is enhancement of the facial nerve. And the facial nerve is going through its canal, as we have mentioned in the anatomy. An enhancement of the nerve without any appreciable enlargement or localized mass is diagnostic of facial neuritis. And this diagnosis cannot be reached unless you have MRI with contrast material, and you may also support your technique by FATSAT. Then you are able to see the enhancing nerve, and you diagnose the inflammation of this nerve. Then this is non-specific inflammation. It can be idiopathic, can be secondary to herpes. The classic appearance, the classic clinical appearance is not necessary to be imaged by CT or MRI, but if the course of the facial neuritis is not resolving or the course is progressive, then you should have imaging to exclude the possibility of a tumor. The diagnosis is based on enhancement of the facial nerve with no masses or focal enlargement. Then the next case is the CT of the salivary glands, showing a mass in the left right parotid gland. Yes, this is right. This is parotid carcinoma. Whenever you are asked about the type of this carcinoma, you should say that this is either adenoid cystic or mucoepidermoid, because squamous cell carcinoma do not usually seen in the salivary glands. How can you know that this is malignant, not benign? Because of the invasion of the surrounding structures and obliteration of the subcutaneous tissue between the tumor and the skin. Also, if you can see metastatic lymph nodes or destructive changes in the mandible, this is not seen in this case, then you suggest that this is a carcinoma. Then whenever you are asked about the differential diagnosis, you say lymphoma, and next to it you say metastasis. Then you should diagnose all these lesions as carcinomas until proved otherwise. And the next step is to have a biopsy from this lesion to confirm the diagnosis. And at the biopsy, it happened to be a parotid lymphoma. Parotid lymphoma is not usually heterogeneous, and there is no areas of breakdown in most of the cases, but it happens so. Then many of the clinicians refer this patient not instead of having a biopsy to have a PET scan, and this is useless, of course. PET scan is not a diagnostic tool. It cannot differentiate carcinoma from lymphoma from metastasis. Then the best way is to go first for biopsy. Then if you need to, if the biopsy has resulted in a malignant lesion and you need to stage this malignant lesion, you may got the help of PET scan. And this is a case of I think is frequently seen in the exams because of the strange appearance, but the diagnosis is quite easy. And you see here, this is CT scan axial and the coronal with contrast, and this is axial MRI, T1 axial and the coronal and the sagittal with contrast. Then, no, this is not a craniopharyngioma. Craniopharyngioma should have a cystic component and a solid component, but you can feel that this is the cystic component from the CT scan, but this is not the case on MRI. There is no cystic component in this tumor. It is absolutely solid and heavily calcified. And also it is not a supracellular, it arises from the skull base. No, this is not angiofibroma. You remember from the musculoskeletal system that the tumor with extensive matrix calcification is in favor of chondrosarcoma. And you know that skull-base chondrosarcoma is a frequent lesion seen in the clinical practice because there are a lot of sites that chondrosarcoma can arise from the skull base, and the clue for diagnosis is the presence of a solid lesion heterogeneously enhanced with extensive calcification. Then sometimes there is some overlap between chordoma and chondrosarcoma, but chordoma is a little bit inferior in the region of the clivus, while the chondrosarcoma is a tumor of the sometimes the middle cranial fossa and sometimes the posterior cranial fossa. Then this is a post-contrast CT scan of the mouse floor. Chondrosarcoma can occur in the midline and can occur off the midline. Depends on the site of origin. Okay. Calcular sialadenitis, you do not see a stone here. This is actually the left submandibular salivary gland, and the right one is involved by this mass of heterogeneous enhancement. In order to differentiate between malignancy and inflammation, which are almost similar together, you should look for the subcutaneous fat. If the subcutaneous fat is stranded, smudged, reticular, then you consider inflammation. If the subcutaneous fat is clear like this one, and you consider malignancy. Malignancy can show heterogeneous enhancement like this one, but it does not, it is not associated with such an inflammatory reaction in the subcutaneous tissue. And this is submandibular space abscess. You know, the submandibular space is located lateral to the genioglossus muscle. It contains the submandibular salivary gland and the part of the mylohyoid muscle, some lymph nodes, and this space is involved by this inflammatory reaction. The next case is a CT scan of the petrous bone, axial with contrast, and bone window axial, bone window coronal. The subretive sialadenitis, yes, this is right. And this is glomus jugular. Yes, this is the glomus jugular, a tumor which is centered to the jugular fossa. The jugular fossa is destroyed with an enhancing soft tissue component, which usually extends in many directions. Sometimes this tumor can go inside the middle ear cavity. At that time, it is known as glomus jugulotympanicum. It has the two components inside the jugular fossa and inside the middle ear cavity. Then you call it glomus jugulotympanicum. The next case is also for the petrous bone. This is CT scan and this is MRI T1 post contrast with fat saturation. Glomus tympanicum is diagnosed whenever you see a glomus lesion inside the middle ear cavity. And this tumor does not usually infiltrate the surroundings and does not cause ossicular chain destruction, and is clearly identified by the otoscope. But the glomus jugulotympanicum is a big one that has destroyed the jugular fossa, the borders of the middle ear, and extended inside the tympanic cavity. Yes, this is automastoiditis. Yes, right. The diagnosis is right. You got a pacification of the mastoid and middle ear cavities. The ossicles are intact, and this is a simple case of automastoiditis. Next is a big lesion in the region of the parotid gland, and these are the possibilities. Tonsillar carcinoma, parapharyngeal abscess, parotid tumor, suppurative parotitis. The answer is C. No, I just mentioned that you should look to the fat. You should look to the fat. The fat is stranded. This is inflammation. If the fat is clear, then this is a tumor. This is one of the major differentiating points. Then the next, you got a cystic lesion in this particular location. Do you think it is a necrotic lymph node, branchial cleft cyst, neck abscess, or cystic hygroma? The answer is B, yes, and this is branchial cleft cyst, second arch, which is located anterior to the edge of the sternomastoid muscle, posterior to the submandibular salivary gland, lateral to the carotid and internal the carotid vessels. A lesion in the parapharyngeal space, and this deep lobe parotid adenoma, glomus vagal, nasopharyngeal carcinoma, or carotid aneurysm. Yes, and this is glomus vagal. Yes, the answer is right. Okay, the next case is a male 16 months old with MRI T2 and T1 post contrast with fat sat and another section at the level of the cell. Yes, retinoblastoma, which side? Bilateral. And this lesion? And it's tri, not tetra. Trilateral retinoblastoma, meaning that you got a tumor in the left eye, another one in the right eye, and another tumor in the region of the pineal body. This is not known as trilateral retinoblastoma. If you got another lesion in the suprasellar area, and this is tetralateral or quadrilateral retinoblastoma. This is trilateral, bilateral retinoblastoma, and pineal body tumor. Next case, and you see a cystic lesion anterior to the thyroid cartilage. This is laryngeal chondrosarcoma, calcified thyroid nodule, foreign body in the esophagus, none of the above. Yes, the answer is D, of course. This is none of the above. And this thyroglossal duct cyst with in carcinoma, thyroid carcinoma, papillary thyroid cancer inside the cyst. You know that the only midline cyst in the neck is the thyroglossal duct cyst. If you see a mass inside this cyst, a mass, not fluid level, a mass, you consider thyroid carcinoma inside the thyroglossal duct cyst. Then you look here, this is T1 and this is T2. What do you think about the sphenoid sinus? Fungal sinusitis, sinonasal bulbosis, inverted papilloma, and the mucocele. Yes, the answer is A, and this is fungal sinusitis. You see that the fungus is of relative increased signal in the T1 and very dark signal in the T2. And you feel that the sinus is clear in the T2 because the fungus is very black, similar to air. This is classic appearance for fungal sinusitis. Coronal MRI T1 with contrast. No, this is not invasive. Yes, and this is invasive pituitary adenoma. The craniopharyngioma is a lesion occurring in the suprasellar area. But if you see a mass arising inside the cella, then has extended in the suprasellar area, and you know that this is pituitary adenoma. And if this adenoma has invaded the sphenoid sinus, then you call it invasive pituitary adenoma. Axial and coronal T1 both contrast. Okay, and if you look carefully here and you see that there is inflammation of the sphenoid sinus with marginal enhancement denoting sphenoid sinusitis, and sphenoid sinusitis is one of the common causes of cavernous sinus thrombosis. You see that the cavernous sinus is enlarged and is enhancing in the coronal image, and you can see the filling defect corresponding to the thrombus inside the cavernous sinus. But it's important to understand that the sinus may be totally thrombosed and is still homogeneously enhancing. And sometimes it is not enhancing at all. But the clue for cavernous sinus thrombosis is the presence of the cause, which is commonly the sphenoidal sinusitis. And this is cavernous sinus thrombosis secondary to sphenoid sinusitis. Next is CT scan and an MRI T1 both contrast. No, and yes, finally, this is the craniopharyngium. This is a suprasellar area. In spite of the axial image, you can feel that this is a suprasellar lesion. and it has a cystic component and calcification. An MRI, you can see some solid component which shows some contrast enhancement. But you remember that in order to diagnose craniopharyngioma, you should have two of three criteria. The three criteria are cyst, calcium, and solid component. The cyst should be present. The cyst is an essential criterion, but calcium cyst with calcium, okay. Cyst with solid component, okay. But calcium with solid component, no. And this is a craniopharyngioma. Okay, this is a CT scan of the maxillofacial area or the salivary gland region. Then after contrast enhancement, why calcium in MRI is not seen? This is a very common situation because you know that MRI is insensitive to calcium, even it is very dense like this. And in the lectures, I said if you are interested to see calcium on MRI, and it should have the gradient image or you should have the susceptibility weighted image. But even this very dense calcium is not seen in MRI because of the minor sensitivity of MRI to calcium. And what do you think about this case? Abscess, no. Thrombosis, yes. Of what? Thrombosis of what? Yes, yes, right. And this thrombosis is known as Lemerrier syndrome. And you know that this is the common carotid and internal jugular vein. This is the common carotid, which is patent. Internal jugular vein is thrombosed. And there is inflammation around the thrombosed vein. And this is the clue for Lemerrier syndrome, which is inflammatory thrombosis of the internal jugular vein. This is, of course, is not a lymph node because simply you should have the the common carotid and the internal jugular vein. The internal jugular vein is not seen, and it is thrombosed and thrombosed secondary to inflammation, and this is known as Lemerrier syndrome. Male, 3 years old, with fever, weight loss, and neck swellings. Okay, there is a question about Lemerrier. If you look here, and this is the common carotid artery, and this should be the site of the internal jugular vein, similar to the opposite side. This is the common carotid, and this is the internal jugular. But here you see the internal carotid, but the internal jugular is thrombosed. Not simply thrombosed, but inflammatory thrombosis because of the soft tissue edema and swelling around the thrombosed jugular vein. Inflammatory thrombosis of the internal jugular vein is known as Lemerrier syndrome. Next. Um, um, I don't understand these answers, but okay, let us answer this case about the child, 3 years old with neck swellings. Yes, These are lymph nodes, of course, because they are located at the anatomic sites of lymph nodes around the submandibular salivary gland and deep to the sternomastoid muscle. Necrotic nodes in the pediatric age groups consider TB. Consider TB, which is the most common cause of necrotic nodes in the pediatric age group. But in adults, necrotic lymph nodes can be inflammatory, can be metastatic. But in the pediatric age group, we think usually of TB, cervical lymphadenopathy. Then this is a child, 6 years old. This is a difficult case, of course. And you got the CT scan of the orbit and the soft tissue and the bone window. I know it is a difficult case, but this plastic lateral orbital wall, no. Optic nerve lesion. Okay. If you look carefully, you see that the orbit is enlarged. And inside the orbit, there are soft tissue densities and the calcific shadow. In the bone window, the calcific shadow is just a tooth. And a tooth with a soft tissue component, then you know that you are dealing with a dermoid cyst. Exactly similar to that occurs in the ovaries. If you see a soft tissue component with a tooth, even you see the tooth in the plain film. And this is orbital dermoid or teratoma. Yes, this is the right answer. And I know this is a difficult case because this is a rare presentation of dermoid cyst in the orbit. Usually you got cystic lesion with intracystic fat fluid level sometimes, but the fact that you can see tooth derivatives and so on, this is a little bit rare. And هذا وبالله التوفيق. وإذا حد